Let's talk about this one. It's a tricky step one question. Where does the thyroid come from? Well, in embryonic development around the 4th week, you get the thyroid gland, which starts as a little patch of cells at the base of the tongue in a spot that's called the foramen cecum. And this spot is between the anterior 2/3 and the posterior 1/3 of the tongue. And so then the thyroglossal duct is going to form, and as the thyroid develops, it descends from the tongue down to the funnel position in the front of the neck, just down in front of the trachea. And it travels in a path known as the thyroglossal duct. It's like a little tunnel that guides the thyroid where to go. And the duct is normally temporary, and it's supposed to shrink and disappear in a process called involution. What goes wrong? In the cyst, sometimes the duct doesn't go away, and instead some epithelial cells, like the cells that line the tongue, will stay anywhere behind the duct's original path. And these cells can start to collect fluid and mucus, forming a cyst, and that's the thyroglossal duct cyst. Ooh, gross. And they show up anywhere on the whole path. Most commonly, though, they're in the midline of the neck. So that's why it's pathognomonic, right? And so, yeah, it's noticeable after an upper respiratory infection like a cold or a sore throat because the cyst becomes secondarily infected by those guys. So key features: midline, moves when swallowing, seen in kids. Cystic, fluid-filled. That's pretty much all we got. So now let's dive into this question. 6-year-old girl, pediatrician, swelling in her front neck that they noticed while she was brushing her teeth. Swelling has been enlarging. On examination, she's afebrile. She's doing fine, but surgical examination and surgical excision is planned. The findings will show a structure derived from what embryological pathway? Okay, so that cyst has not gone away, and so it's going to be the incomplete involution of the thyroglossal cyst. Hopefully that was a really good explanation. If you're done, if that makes sense, watch the next video. But let's just dive in and explain why the other answer choices are wrong. So, A, the failure of the pharyngeal cleft obliteration. That's a bronchial cleft cysts. And these guys are lateral, usually anterior in the sternocleidomastoid. This guy right here, see that? And they don't move when swallowing. So that'd be the failure of the pharyngeal cleft to obliterate. Abnormal descent of the parathyroid primordia. The parathyroid glands are derived from the 3rd and 4th pharyngeal pouches, and aberrant migration causes ectopic parathyroid tissue, but not midline cysts. Maldevelopment of the branchial arch mesoderm, that would be like Treacher-Collins syndrome, not even relevant here, but facial and muscular abnormalities. Persistence of the cervical sinus, that'd be a remnant of the clefts 2 to 4, and it causes lateral neck cysts, not midline masses. So remnants of the cervical duct, the cervical thymopharyngeal duct. Ectopic thymic cysts can occur on the path of thymus descent, often the lower lateral neck, usually on the left side, deep to the sternocleidomastoid. So not that. Basically, thyroid develops from the foramen cecum, descends down, and then it normally disappears. But if you don't involute it, then it's midline and moves with swallowing, and it's seen in children, and it gets infected through respiratory infections. We'll see you in the next video. Like and subscribe, and all that good stuff.